Good afternoon again, everyone, and thank you for joining us for our webinar on emergency management of pelvic fractures with Dr. Kaleab Tesfaye, brought to you by in collaboration with the Ethiopian Medical Association. So before we start, I would like to say a few introductory remarks about Yetena Weg. Yetena Weg is registered in Pennsylvania, USA as a non-profit organization, and it's run entirely by volunteer members, whose pictures you can see on the right upper corner. We have more than 70 active volunteer members spanning across 5 different countries and counting more at the moment. So Yetena Weg's activities or projects and engagements can be seen in 4 aspects. The first is health promotion, which is done via discussion and articles concerning the health of the general public, health policy and its implementation. Our second is our community engagement project, which is done through blood drive, inclusivity, equity projects, and fundraising campaigns. Our third and one of our strongest programs is mentorship and skill sharing, where we provide direct mentorship, soft skill, career and professional development webinars to our to healthcare professionals. And the last is medical education, which under it has the CME research and QI projects. So Yetena Weg is more than a digital platform, provides a platform where the volunteers can come together, provide or give back to the community in a meaningful manner. As you can see from this image, from this slide, it's an image showcasing our volunteers in various activities we held throughout the years. So one of our other projects is the Yetena Weg Roha Health Article Writing Competition, which is prepared in collaboration with IMSA. So the first round of Health Article Writing Competition has already been announced. We've received more than 40 submissions so far. So Roha Medical Campus will award travel grants for 2 healthcare article writing competition winners, whereas Yetena Weg will award Pulse Oximeter for the top 20 and Litmus Stethoscope for the top 3 winners. And the top 5 winners will get internship opportunities at Roha Health and other partner institutions. So these are the posters we've used throughout the competition. So this is another slide showcasing the winner from 2021 and the prizes for the 2022 winners. And these are the 2023 article writing winners that got the opportunity to travel abroad. Our other engagement is the Yetena Weg Roha Research Fellowship, which is done in collaboration with Roha Medical Campus through its Roha Health Foundation, the Tukur Ambassa Specialized Hospital and St. Paul Hospital Medical College. So the first round started on March 14th of 2023. 3 departments at Addis Ababa University Medical Faculty were involved, mainly oncology, radiology, and internal medicine. Research grant was awarded for the top 4 winners. The other participants were from St. Paul Hospital Medical College. So it was prepared for medical students, mainly medical interns, and research grants for top 4 winners have been announced. These are the winners from the Tukur Ambassa Specialized Hospital, and these were the winners from St. Paul Hospital Medical College. So when we come to our CME sessions are freely accessible, and we partner with the Ethiopian Medical Association, Ethiopian Society of Cardiac Professionals, and the Ethiopian Medical Association to provide continued training for healthcare professionals. We've had 27 CME webinars held so far. So we invite renowned local and international speakers, and our average webinar attendee usually spans from 150 to 200. So for the year 2024 alone, we have more than 30 webinars focusing on emergency surgical, medical, ANT, pediatrics, OBGYN, and oncology cases. And you can access our previous CME sessions by going to our Yetena Weg YouTube channel. And you can get updates about our upcoming CMEs. Links to our social media outlets will be posted in the chat box below. So in order to get the best experience from the webinar, we urge you to send your questions on the Q&A or in the chat box. And at the end of the webinar, your questions will be addressed by the guest speaker accordingly. And in order to get CU certificates, you must fulfill the following 3 set of criteria. The first is attend the whole session virtually. The second is fill in the Google form for personal details and attendance. And the third is get 50% and above on the post-webinar quiz. So you may be able to see your results right away, but the process of issuing certificates can take up to 2 weeks. So we ask that you wait patiently in the meantime. So having said that about Yetena Weg, I would like to introduce our guest speaker for today. Our guest speaker today is Dr. Kaleab Tesfaye. Dr. Kaleab is an orthopedic trauma and spine surgeon currently working at the Armed Forces Comprehensive Specialized Hospital, and is also a part-timer at Axon Stroke and Spine Center. He completed his medical degree at the University of Gondar in 2015 and did his orthopedic surgery residency at Addis Ababa University Department of Orthopedic Surgery in 2020. In the same year, he graduated from the College of Surgeons of Eastern, Central, and Southern Africa, or COSEXA. He completed his orthopedic trauma and spine fellowship at the Ganga Hospital in India in 2023. So Dr. Kaleab treats patients with a wide variety of spinal and musculoskeletal issues. He helps patients return to their regular activities by addressing orthopedic problems such as spine conditions, extremity and spine fractures or dislocations, back and neck pain, and spinal deformities. His interests in orthopedic care include spine trauma, degenerative spine conditions, spine deformities, spine infections, malignancies, complex trauma, pelvic and acetabular fractures. He's very passionate about providing high quality health care to all his patients. He performs minimally invasive procedures to reduce pain and ensure shorter hospital stays. This approach helps patients recover quickly and return to their normal, healthy lives. So, without further ado, I would like to give the floor to Dr. Kaleab. Dr. Kaleab, please proceed.
Okay, thank you, Yetena Weg team, for introducing me. So I'll just go straight to our today's session, which is emergency management of pelvic fractures. So thank you again. Today we are going to discuss about acute management of pelvic fractures. These injuries are common in high trauma settings, may not be that much common in rural areas because they involve high energy of trauma. And most patients who sustain high energy trauma, they may not make it to healthcare facilities. So they're a little bit rare when compared to other injuries. So pelvic ring injuries, they are high energy injuries. Usually they follows road traffic accidents and fall from height. They are associated with high morbidity and mortality in patients, and they are associated with a significant amount of internal hemorrhage in these patients. So when we consider pelvis, it's somehow we used to think it as a cylindrical structure, but it's a hemi-elliptical sphere. So when you see this image, the black cylinder is a normal cylinder. When before, like prior to pelvic ring disruption, whenever there is high energy trauma which disrupts this pelvic ring, it starts to enlarge in size and attain the one on the red cylinder. That means it starts to accompany a large amount of blood inside it. So it might even accompany up to 5-6 liters. That's the whole blood of the patients. So that's why we need to focus on these injuries, because they can accommodate a huge amount of blood. So immediately after trauma, the patient will have significant internal bleeding inside the pelvic cavity. So to compare, the cylinder volume is 4/3 times pi r square. So whenever the radius of this sphere or the radius of the pelvis increases by 1 centimeter, significantly it start to enlarge by the power of 3. So a significant amount of volume enlargement will happen inside the pelvis, which result in significant amount of blood loss. So when we start to evaluate these patients, usually these are like high energy trauma patients. So we should start with primary survey, as we do for most patients, almost all our trauma patients. We start from airway, breathing, circulation, disability, and exposure and environment control for these patients. So specifically pelvic ring injuries, we are concerned. We are dealing with circulation problem because it poses a significant bleeding inside the pelvic cavity. So we are dealing with managing circulation. So circulation in with hemorrhage control. So by reducing the pelvic volume, indirectly we are arresting the internal bleeding. So in most of our patients at a primary care setup, there is no setup for managing these patients. So after stabilizing those injuries, after stabilizing the life-threatening injuries, there are certain considerations that we should consider for transfer these patients to specialized center or primary trauma care setups. Like if we see significant anterior-posterior instability or displacement on the initial AP X-ray, if we see significant gross displacement on these pelvic X-rays, that we should care these patients primarily, arrest the bleeding, make the patients stable, and then we should prefer for better management for a specialized center. The other is bladder and urethral injury. These patients need referral for these bladder and urethral injuries after stabilizing them. The other is open pelvic injuries. These are like the mortality associated with open pelvic injury is significant, even more than closed injuries. So after stabilizing these patients, this definitely needs to be referred at specialized centers where pelvic fracture management is possible. So the other is lateral. These are lateral compression. We call them lateral compression injuries. So these are usually associated with significant amount of chest and head trauma. So we may not be able to definitively manage these patients. So they are one candidate for referral for primary, the trauma center, in trauma centers. The other is significant pelvic injuries with anterior-posterior compression injuries with significant anterior ring displacements. I'm going to show you later in the seminar. So these are candidates for referral for specialists after evaluating and stabilizing these patients. So on examination, after you finish your primary survey stabilizing the patient, specifically when we start to manage these pelvic injuries, we should be able to look for these things like degloving unit. So degloving injuries per se doesn't mean we need to see open wounds, open or degloved skin which is visible. But in pelvic injuries, there is subcutaneous degloving. We call it a moral level lesion. So these are one indicators of significant pelvic fracture. So whenever you find a patient, you may not be able to know whether the patient has a pelvic fracture or not. So this is one telltale sign that the patient might have sustained this pelvic fracture. The other is limb shortening, even though it's shared with another extremity injuries like hip and long bone fractures. Limb shortening is one sign to consider pelvic fracture. The other is limb rotation, and the other findings are open wounds over the perineal area, over the anterior, posterior, lateral sides of the pelvis, and obviously the patient will have significant swelling, hematoma collection, and tenderness over the pelvic area. So how do we define stability? So to define like whether pelvis is stable or not, the first is a radiographic sign of stability. That is like on the X-ray that here you are seeing there is significant pelvic disruption. If I can zoom. Okay, so I'm going to show you here. So like this is one side of the pelvis here on the black, and here is another side of the symphysis pubis. So you see how much significant the diastasis or the disruption is anteriorly. So this is one sign of unstable pelvis. So this is what we see on the anterior ring, whether there is symphysis disruption, we see ramus fracture here, ramus fracture here, and these are the things that we should see or evaluate on AP X-ray on the anterior ring. The other is on the posterior ring. We should be able to see. So this is where I circle is the area where intact SI joint is, but here if you see, here is the iliac part of SI joint in the sacral point of SI joint, and then you can see how much distance there is. So there is a significant gap. So these are growth signs of radiologic signs of pelvic instability. So the other things are indirect signs that we should use. So if you see up on the transverse process of L5, these are attachment sites for iliolumbar ligaments. So I'm going to outline the transverse process of the L5 transverse process. They appear like this. So whenever you see any break here, and then we call this avulsion fractures. Whenever there is a break here, we should always consider there is vertical shear or unstable pelvis, because like most of the times, some primary case physicians which are at the scene of accident might apply some pelvic binder, which tends to reduce the pelvis. So in that case, you might not be able to see these significant gaps. So it's already reduced. So there are like, these are indirect signs of evaluating the pelvic instability. So the second one is just evaluating the lateral aspects of sacrum around here and around here. So if there is any avulsion here, it means the ligament attachment to the sacrum, so sacrotibialis ligament, might avulse the sacral portion of lateral part of the sacrum. And also you might even see the avulsions from tuberosity, ischial tuberosity. So these are like signs of instability that we should look for in patients with pelvic trauma. So the other assessment is stress test. Usually, we don't advise physicians to do stress test. It should be done with like trauma surgeon or pelvic surgeon, because if there is some new finding after like trying to check for stability, if there is progressive hemodynamic instability after that, the fracture fragments might have pierced like a major basal or some visceral structures. So we recommend trauma surgeons to do this stress test under fluoroscope. The other test is the weight-bearing view. We call it a flamingo view, one leg stance view. So this is an X-ray which has taken, which has like the patient has this pelvic ring disruption, as you can see it here and here. So we will evaluate these patients whether the pelvic ring is stable or not. If we couldn't see, or if there is no gross abnormality in the posterior ring. If the ring is broken at two places, like anterior and posterior, that we should consider that pelvis as unstable pelvis. But if the X-ray looks intact on the posterior ring, and then if there is no access for a CT scan, we can have weight-bearing or flamingo view to see any gross displacement there. So here there is no significant hemipelvis displacement, or you can consider this pelvis as a stable pelvis. The other is hemodynamic instability. We are going to discuss this later on. And the other is mechanical stability. That's when the pelvis is able to withstand normal physiologic forces without abnormal deformities. That's mechanical stability that we already checked with these stress views. So our next slide is, as I said before, so in this AV pelvic X-ray, you see this oblique superior ramus and longitudinal inferior ramus fractures. They look reduced. It doesn't look, it's unstable. So these are the cases where we should try stress views. So single examiner should do it only once, and then it should be recorded, and we should use intraoperative or like in the emergency if it's available fluoroscope, and it should be done in best experienced hands. So when you see, when the surgeon tries to replicate the initial mechanism of injury, that is lateral compression injury, see how much the pelvic ring closes up. That's significant displacement. So this pelvis should be considered as unstable pelvis. So as I said before, radiologic signs of instability, SI displacement more than 5 mm in the posterior ring, posterior fracture graft rather than impaction. Usually impaction injuries, they are considered to be stable, but not for all cases. And as we have discussed before, avulsion of fifth lumbar transverse process, lateral border of sacrum, sacrotibialis ligament, and ischial spine for sacrospinous ligaments. So open pelvic injuries, these are the one scenarios that we can find in these patients. So open injuries, usually if you see like in the long bones, femur or tibia, we should be able to see these openings out like by our eyes. So they are like externally open injuries. But for pelvis, because it's near to some visceral structures, it might be open from the inside also. So like these fractures might rupture the bladder, the structures might rupture the colon or rectum. So that they start to communicate with external environment through this viscera. So they are called internally open injuries, and then we should specifically look for those things by doing proper per rectal examination, per vaginal examination in women. And also if there is a CT scan, on CT scan, if we find some gas bubbles inside the fracture site, these are by definition internally open injuries, and then these are the top emergency cases that we should transfer them where the definitive management can be done, like diverting colostomy or vaginal repair in the case of vaginal lacerations due to pelvic fracture after actually stabilizing the patient primarily. So urologic injuries are another cause of injuries that we should look for. So there are like around 15% incidence of urologic injuries, and the telltale signs are blood at the meatus. If you see blood at the meatus or high riding prostate on your rectal examination, we shouldn't try to put Foley catheters for these patients. They are the candidate for suprapubic catheter placement, because we might even further injure these urethral injuries. So we might sometimes have eventual swelling of scrotum in labia. Sometimes they might even need arterial bleeder arrest. They might need this, but it's in rare scenarios. So the other is we might have to do retrograde ureterogram if there is any suspicion of urethral injuries. So we need a urologist consult for this case. And bladder ruptures can be intraperitoneal, extraperitoneal injuries. And for these patients, Foley catheter is preferred. But so if the surgeon needs to put a suprapubic catheter, so we need to communicate with the urologist or the surgeon, which is going to put a catheter they need to tunnel it away from the surgical site over the panelist incision area, because most of our pelvic incisions tend to lie there. So we don't want any infected tract to track to our implant site. So we need to communicate with the urologist not to put suprapubic catheter through their suprapubic incision site. So they need to tunnel it away from the definitive surgical incision sites for orthopedic or pelvic fracture management. So when we see source of hemorrhage in these patients, so external or open wounds might be there, generally as a trauma patient, and then internal bleeders in the chest, long bones, abdominal, and retroperitoneal are like the areas we should look for. One is retroperitoneal space, where that means like pelvic cavity, which can accommodate huge amount of blood. So we need to look for these injuries. We need to have a chest X-ray. We need to do our physical examination, look for any significant swelling where there is potential vascular injury. Currently, we are doing fast diagnostic peritoneal lavage. I don't think is being done. Is replaced with fast in ultrasound and CT scan, and directly by examining it for external bleeders. So how do we assess for low tissue perfusion? Because we are dealing with a polytrauma patient here. So we need to assess patients in tissue perfusion. So there are like clinical and biochemical markers to pick this, so that we know that we achieve this end goal of our resuscitation. So from clinical is systolic blood pressure less than 90, which shows low tissue perfusion. if there is any ongoing drop in hematocrit, we should follow serial hematocrit in these patients, and then we should also assess response to our initial fluid challenge. And the most sensitive are these biochemical markers. That is lactate level is the most sensitive and specific for end tissue perfusion. And the next is base deficit. So which pelvic fractures are at high risk of hemorrhage? Like for which fracture patterns that we see on the X-ray that we should consider a significant amount of blood loss in this patient. So fracture pattern associated with risk of vascular injury are there is a Young and Burgess classification I'm going to show you later. So for external rotation, that's open book injuries with significant displacement, like the X-ray we saw earlier, and vertical shear injuries where one of the hemipelvis has sheared upwards. So these patients are has the highest risk of vascular injury. That is arterial injury. So we are more worried on arterial injuries because they have a low tendency to respond out to our resuscitative measures and our measures to stop the bleeding. But most of venous and the bleeding from the joint surfaces, fracture surface, and torn ligament surfaces, they are most likely to control with our usual routine techniques of hemorrhage control. So anterior posterior compressions and vertical shears that, as I said before, are at high risk of bleeding and hemodynamic instability. So the other is some fracture patterns, like fracture patterns which extends to the greater sciatic notch, because those areas are the areas where the neurovascular structures will cross. So any fracture which extends to greater sciatic notch has a tendency to prick these arteries, which might result in significant blood loss, which might not respond for our routine resuscitative measures. So this is one of the common, we have different classification systems, but here I present you with Young and Burgess classification. There are three gross classifications. One is lateral compression, the second is anterior posterior compression, and then vertical shear. So this depends mainly on the mechanism of injury. So if the patient sustains lateral compression, so for example, if the patient is trying to cross a road and then sustained injury from the side, from a moving car, is going to have a lateral compression injury. These are injuries which are associated with significant risk of injury for head injury and chest injury. The anterior posterior compression is, as the term describes it, if the mechanism of injury comes from the front to the back, like when a driver or front seat passenger sustains it on head-on collision, and then there is a compression from anterior to posterior. So depending on the energy of the injury, the ligaments in the pelvis, so the bone of the pelvis, start to fail from anterior to posterior. So in level 1 only, there is on type 1 there is symphyseal diastasis. When the energy is more higher, that patient will start to lose or rupture its anterior sacroiliac ligament, but posterior will be intact. And then if it's further progress and then have more significant injury, the patient will have injury to the posterior sacroiliac ligament. That means that one of the hemipelvis is floating, which makes this injury highly unstable. The third type is vertical shear injury, which whenever the patient fell from a height and landed on one leg, the energy will be transferred only into one hemipelvis and it starts to shear upwards. And this is considered to be a high energy trauma or which is associated with high risk of internal bleeding. So how to control this bleeder? So this is part of C from primary survey ABC. This is part of C. So whenever we see a bleeder outside, we are going to arrest it with a direct pressure. But for internal bleeder, especially on the pelvic, which follows pelvic fracture, we need to contain or we need to reduce the diameter of the sphere. As I showed you before, the sphere is will become wider during this disruption of the pelvic ring. So we need to close the ring so that the volume of the pelvis will be smaller, so the capacity of the pelvis to accommodate a huge amount of blood will be minimized. So there are like different techniques to arrest this hemorrhage. The first is pelvic containment with pelvic sheath, normal routine sheathing, and pelvic binder. There is these are the commercially made binders which are applied at the pelvis, and there is external fixation is also used as a pelvic containment technique. And the other is, if there is no improvement, I'll show you how there is a cascade of managing these patients. If there is no improvement despite pelvic containment, we might need even to go for angiography and immobilization. Plus, if there is any abdominal bleeder, we might need to do laparotomy. Plus, pelvic packing is one way to control the pelvic bleeders. Okay, so I'm going to show you a simple technique how you can apply pelvic binder. I'm going to show you, so the patient is supine. It's better for me to show you one video. So you'll see this video and we'll be back. So patient is supine. So here, I'm going to show you. So two guys on one side of the patient will rotate the patient so that like one physician will be on one side of the patient so that they can pass the folded sheet. This is normal routine sheet, bed sheet. So they will roll the binder. I will show you how it's rolled, if you can see here. So two of the physicians on one side, they will do the log roll technique to turn over the patient. One physician will be at the head side, preferentially anesthetist or anesthesiologist on the head side. And then if it's available, if there is a team is complete, one physician should be at the side of the patient's legs so that they can stabilize the pelvis while rotating the patients. Or if the patient has a vertical shear, they can apply a gentle traction on the legs to reduce the pelvis from its vertical position to a little bit lower so that you can effectively close the pelvis when you apply the pelvic binder. So two guys on one side. So one guy folded the sheet like this. So they folded the sheets into and rolled the sheets from two sides. So one guy's, if you see on the head, stabilize the C-spine. So these guys do the log roll technique. And then one physician will pass the pelvic sheets like this. And then some rolled part of the sheet should remain like this so that when the patient is log rolled on the other side, so that they can have a good grip of this pelvic sheet. So they will pass it like this, the rolled parts. And then when it's done, these two physicians will go on or healthcare providers will go on the other side and then log roll. See like how much of this rolled sheet is remaining. So you can unroll this so that you will have a good grip of this binder. See? Okay, so they already passed it. So one of the physician or the healthcare provider will pass the sheets on this side, as you can see here, and then receive the contralateral side, and they will pull. If you see, they both held at the edges of the sheet, and then they apply a good amount of traction on these bed sheets like this. So we need to prepare 4 clamps or bigger arteries to clamp on 4 places. So they are, as you see, they are pulling it. So they are like, they have a good amount of pull so that it can close the pelvic ring. So we have 4 clamps here, so that they will be applied at 4 places. So the one basic thing you need to see here is the center of this pelvic sheath should center on the greater tuberosity of the femur. So like some people will make the pelvic binder upwards over the anterior superior iliac spine or over the abdomen, which opens the pelvis from inferior side. So the center of the pelvic diameter is at the, like where you can close the pelvic ring is at the center of the GT. So like your pelvic sheath should center on the greater tuberosity so that you can have effective closing of pelvic ring. See, they are done with clamping the patient. So after this stage, you can continue with resuscitating this patient. Okay, so it should take 30 seconds because like it's just for demonstration that they take a little bit longer, but it's a 30-second procedure so that you can arrest or reduce the pelvic volume. Okay, so this is the patient we already saw previously. You can see how significant the pelvic diastasis, the symphyseal diastasis anteriorly, and also posteriorly there is significant SI disruption. And then after pelvic sheath application, see how much it has closed the pelvic ring and reduced the volume of the pelvis. So this is before sheath application, and this is after sheath application. So you see how much is significant. You can attain significant reduction in pelvic volume. So when we put it side by side, you can see there is a significant reduction in pelvic volume. Okay, so this is a commercially available pelvic binder, because in most of our setups we don't have these pelvic binders. So that, like I have showed you, that pelvic sheathing is a good way of using pelvic or pelvic containment. So this is a commercially available pelvic binder that you should put at the center of the GT, at the level of the GT. Okay, so the next thing is, this is more advanced for orthopedic residents and fellows. So external fixation. So there are different types of external fixators that we can apply over the anterior superior iliac spine, like that's iliac, over the iliac crest, and anterior inferior spine, that are suprastabular external fixators, and the C-clamp when you have a significant posterior ring disruption, so that you can apply or reduce posterior ring. And external fixators can be used as an initial means of resuscitative technique, or it can be used as augmentative, as additional tool for your internal fixation, and as a definitive for some portion of patients where you can't operate the patients. It can be used as a definitive way of managing this patient, but it's not advisable unless it's impossible to fix the patient due to certain factors. So biomechanics of external fixator. So usually C types, they are good at C clamps, they are good at controlling the posterior ring, whereas anterior superior iliac spine and anterior inferior iliac spine pin, they are good at controlling the anterior ring and closing it. And open Pelvic injuries with posterior ligaments, if they are intact, we can do anterior external fixation. But like, what's the problem with fixing it with external fixator anteriorly? If there is instability of the posterior ring, it will open up posteriorly, so it will make our effort less. So for intact posterior hinge, anterior external fixators are a good option of reducing pelvic. So this is the biomechanics of external fixation, a little bit more advanced for primary care physicians. Pin size, number of pins, and frame design, frame location. These are the things that will help us to increase stability of our fixation. So these are like iliac crest pins. They are like put like at the iliac crest like this, as you see on the image. So they're not really good at controlling the pelvis. Rather, like which are good at the superior anterior inferior iliac pins or suprastabular pins they are really good at controlling your pelvis. These are a little bit technically demanding. Usually, you may need to have OR setup where there is fluoroscopy available, but there are like prescribed techniques of putting them with blind technique, but these are a little bit of they require a little bit of expertise. So if you don't have any expertise for these techniques, it's better to put on iliac crest pins. So one advantage of these suprastabular pins is patient can sit comfortably, as you can see, because they are more stable, so that they will reduce the movement of pelvic fractures. So the patient, once you put this external fixator, the patient can sit comfortably. So it will be good for these polytrauma patients for their rehabilitation. So what are indications for external fixation? We have different indications. One is, as I said before, resuscitative, as early management of these fractures. So the other is to decrease pain in the polytrauma patients, and then they can be used as an adjunct for open reduction in internal fixation. And then rarely we can use this external fixation for definitive management. So one example is here. So open book injury, as you see here, the anterior ring is wide, opened up, and also there is a significant disruption of the posterior ring on the left side. Left east side joint is wide, as you can see here. So external fixator can be used to close the ring. That's same as previous pelvic containment techniques that we have discussed. So if you can see here on the inlet and outlet views, you see how significantly it managed to close the pelvic ring, which later had this patient that was temporary for temporary purpose, and then once the patient is stable, all the biochemical markers are stabilized, patient is stable, so we can go for definitive fixation of these patients. So the other is to pain decreasing polytrauma patient, as you have seen before. So the patient usually comfortably can sit after you applied this especially suprastabular. So the other is as adjunct for ORIF for some patients that like for this patient, there is significant anterior ring disruption, there is diastasis, there is biramus fracture, and posterior also there is left side side disruption. And if you have noticed the skin of the patient, that's like this is a morbidly obese patient. So for a morbidly obese patient, internal fixation techniques might not be enough to stabilize this fracture. So we can use this as adjunct for external fixator, and also the patient might be like critical. So we might want to avoid significant dissection to stabilize the whole ramus fracture in diastasis. So we just close the ring with external fixator, fix or reduce and fix simple diastasis, and we can leave the ramus fracture. So that's what they have done. So they have reduced the pelvic volume, fixed the simple diastasis, they have left the ramus fracture, and then they use the external fixator as adjunct for this internal fixation. The other is, even though it's rare, for definitive pelvic fractures. The other technique which we are using is C-clamp, that's anti-shock clamp. So it is applied at the posterior side of the pelvis. Most of the external fixators we use like the external fixator types we discussed there, we applied them at the front. And this C-clamp is, we use this C-clamp whenever there is significant posterior disruption in displacement, especially if the both anterior and posterior SI ligaments are torn, so that like we may need to close the posterior ring, we might need to use this C-clamp. So this is how it looks, and then this is how it goes. Like it goes into the posterior pelvic ring. So it appears like this on this section, the axial section. So you can move it like both upwards and downwards. So access for laparotomy and abdominal access will be much easier. So it is much comfortable for surgeons to access. Okay, here there is a significant posterior ring disruption. So if you just apply external fixator and then try to reduce this pelvis, it's going to open from the posterior. So you are going to like open up from posterior by closing the anterior. So like your pelvic containment will not be as effective as you think. So for these cases, it's better to use pelvic clamp so that you can close the posterior. Okay, so pin location is the same location as starting point of SI screws. The only thing you should avoid is, especially for sacral fractures, you don't want to overcompress these fractures because there is risk of collapse of the sacral fracture, which subsequently would result in nerve injuries. You see this here. There is significant sacral fracture, which has significant displacement destruction, and after application of this C-clamp, there is significant collapse of the neural foramina for sacral nerves. So the patient might end up in nerve injuries and urologic. So after we do all this, if the patient still persists to be hypotensive, or if the patient goes back to hypotension, that's in transient responder patients, we should consider there is a continuous bleeder inside the pelvis. So one technique that we can do comfortably in most part of our country is pelvic packing. So these are prepared pelvic packs. So the advisable pelvic packs are should be radio opaque. So whenever you put up a pelvic pack and then transfer to level 1 trauma center, whenever they took X-ray, they should be able to know where the pelvic packs are and how many you put. But by standard, we should put 6 abdominal packs inside. So 3 on the left and 3 on the right. So 2 will be put on the SI joint posteriorly, 1 on the lateral side, and then 2 on the anterior side. That's like for 1 in each side. It will be 3 on one side and 3 on the other side. Will be 6 packs, which will significantly reduce the pelvic volume, which might help you in maintaining patients' hemodynamic stability. Okay, so after all this, so what will we do if all this pelvic containment, pelvic the packing, if this doesn't help the patient that much, and then if the patient's still in hemodynamic instability, what will he do? The next step will be, so like majority of the bleeders in the pelvis are from the venous plexus. So venous plexus will account for around 85% of the pelvic bleeders. So then the rest will be from arterial bleeders and bleeding from the bone fracture sites, torn ligament sites, and these sites are responsible for the least bleeders. So most of the pelvic, the bone bleeders from the venous bleeders can be arrested with the above mentioned techniques, but if there is arterial bleeder, it sometimes will be difficult to control these bleeders with pelvic containment techniques. So the next step, if the patient persists to be hypotensive, the next step is to do angiography. We need to consult for interventional radiologists to do for angiography. Here on the left side, you are seeing there is arterial bleeder from looks like from internal iliac branch of internal iliac. Most common branches are superior and inferior gluteal artery and obturator artery. Here it looks like a bleeder from superior gluteal artery, so they will do embolization if there is a bleeder. If there is a bleeder intraop, they find during angiogram. Okay, so as I said before, vascular injuries can be like arterial, venous, or cancellous. Like the bleeders can originate from arterial, venous, and cancellous bone. And if there is significant instability posteriorly in the posterior pelvic ring, the risk of arterial injury is higher. That is one. The other is if, as I said before, if the fracture extends or enters into greater sciatic notch, because that's where the superior and inferior gluteal artery will track through and exit from pelvis to outside. So that area is high risk for vascular injury. So whenever we see these fracture patterns in unstable patients, we should always consider there is a possibility of vascular bleeder, and we should go for angiography. Okay, on CT also, it shows there is a bleeder in CT angio. There is a bleeder there, and also these are angiograph pictures which shows arterial bleeders. So with these all steps, it's like we usually will be able to control the bleeder. So on hand to hand, we should able to resuscitate these patients with fluids and blood products. Usually we recommend blood products in 1:1:1 ratio. If fresh frozen plasma, platelets, and packed RBC should be transfused in these unstable patients. So like while we are trying to stop the bleeder, we should be able to resuscitate the patient in the meantime. Other rare scenario is significant crush injury to the pelvis. In this scenario, like there is no place to put pelvic binder, there is no place to put for external fixator, C-clamp, and nothing can work here. So acute hemipelvectomy is one possibility to stop bleeders in this. Like this was the pre-op image, and then this after they do a hemipelvectomy, acute hemipelvectomy, and vascular control has been done. Okay. Okay. So with hypotensive patients with stable pelvic pattern, like I said before, there are signs that we look for in the pelvic X-ray that at least we can be able to say this is a stable pelvic pattern and unstable pelvic pattern. For hypotensive patients with stable pelvic pattern, so we should consider abdominal bleeder. So it's unlikely to have this pelvic bleeders from stable pelvic pattern. We usually anticipate pelvic bleeders with unstable pelvic type. So it's better to proceed to laparotomy than just considering the bleeder is from pelvic fracture. And then intraoperatively, they have found that 85% of patients, they think they have abdominal hemorrhage. So hypotensive patients with stable pelvic pattern, is better to go for laparotomy. But for patients with unstable pelvic pattern, it's better to proceed. Unstable means after all our efforts, if we couldn't control these bleeders, it's better to proceed to angio. So during angiography, if like there are 59% of patients, they are found to be positive on angio. So we are going to manage that accordingly. So we can also do CT contrast-enhanced CT scan to suggest for arterial source. So here is example of a protocol for management of pelvic fracture. We already have discussed it, but like it will help you. Like if you could be able to screenshot this, it will help you to go to deal with these patients. But most of the techniques we already have discussed. Okay, so hypovolemic shock and no response to fluid. That's like this is same as the previous. So if there is positive diagnosis or positive abdominal ultrasound for intra-abdominal collection, it's better to go for laparotomy plus or minus packing with external fixator. But if there is no improvement, it's better to do angiograph. But for negative DPL or negative past study, it's better to put sheet binder, any form of pelvic binder, and then it's better to, if the patient is still in hemodynamic instability, it's better to go for angio. And for hypovolemic shock with response to fluids, if there is significant finding or blood inside during DPL, it's better to go for laparotomy. And if still patient is in shock or go back to shock, it's better to consider for X-fix. No improvement, go for angio. Positive diagnostic lavage is there. We should go for X-fix along with laparotomy. If there is no improvement, we should go for angio. And then if the DPL is negative, we should apply sheet binder. No improvement, we'll go for angio and apply external fixation. Okay, this is the same protocol that you can take a screenshot of this. This also is almost similar to the previous. So protocol of management, like so evolution of multidisciplinary clinical pathway for the management of unstable patients with pelvic fractures, which was published in Journal of Trauma in 2001. So there is 5 elements to have a successful team management. The first is immediate trauma surgeon. We should have immediate trauma surgeon plus orthopedic trauma surgeon, and which is followed by early simultaneous blood and coagulation products, as I said before, in 1:1:1 ratio. And we should be able to promptly diagnose and treat life-threatening injuries. And then we should be able to stabilize pelvic girdle, and we should have the setup to timely do pelvic angiography and embolization. So what has been changed since then? Patients are more severely injured. That like more trauma, polytrauma patients are now becoming more and more. So patients with high trauma injury with significant hemodynamic instability they are like recently coming to a picture. And currently we are using ultrasound instead of DPL. And usually pelvic binders are being commonly used once the patient is stable. We can go for percutaneous fixations and fixations of these patients. So after this so like we should be able to have a teamwork on these patients. So trauma surgeon, orthopedic trauma surgeon, anesthesiologist or anesthetist, neurosurgeon. So it's kind of a teamwork. So we need a multidisciplinary team to manage these patients. So after this guideline has been developed, so mortality has decreased significantly. Days from blood loss has also decreased from these pelvic fractures. Multi-organ, because like persistent hemodynamic instability will contribute significantly for multi-organ failure. So rate of multi-organ failure and also days within 24 hours has significantly reduced. So the evolution of multidisciplinary clinical pathway coordinating the resource of level 1 trauma center and direct by joint decision-making between trauma surgeons and orthopedic traumatologists has resulted in improved patient survival, and the primary benefits appear to be in reducing early days from exsanguination and late days from multiple organ failure. Okay. So this is my summary of acute management of pelvis fractures. So we should play well with others, general surgeons, urologists, interventional radiologists, neurosurgeons. And then we should be able to understand the fracture pattern. And then you should be able to do something. Like the minimum you can do is at least apply a pelvic binder for fracture patterns that are open book nota for lateral compression or LC injuries. And we should combine knowledge of the fracture, the patient's condition, and the physical exam to decide on the next. Okay, thank you.
Okay, thank you very much, Dr. Kala. That was an outstanding session. It was very practical and highly engaging. So I'd like to say once again, thank you for that. Having said that, we'll directly proceed to the Q&A session. My co-host, Dr. Mahalit, will share her screen. We'll go over the questions together.
Okay. Good afternoon, everyone, and thank you, Dr. Kaleab, for the amazing presentation. We have two questions so far. The first one reads, what are the possible X-ray positions we should take to rule out pelvic fracture?
Okay, so so as primary survey, adjunct for primary survey, AP pelvic X-ray is recommended. So most of the pelvic unstable pelvic fractures, even stable pelvic fractures, we can pick them from proper AP X-ray. So our proper X-ray should be like the exposure is from, it should include from L4 of lumbar vertebra until mid shaft of the femur. So we should see the proximal part of the hip, the whole profile of the pelvis, and then L4 and L5 vertebrae. So that with this, there is low rate of missing these fractures. So usually it's better to see, especially for primary care physicians, it's better to see the anterior ring. It may be a little bit difficult to see the posterior ring, whether there is any sacral fracture, a side disruption, posterior sided iliac fractures, because there are a lot of overlaps on posterior structures. So it may need a little bit of expertise. Residents, fellows, and orthopedic surgeons, they are good at picking those injuries, but for primary care physicians, it's better to look for the anterior ring. So you need to see the symphysial distance. If there is any like widening more than 2.5 centimeters, even though it's arbitrary number, if you think that is wide enough, it's better to same for so it's a primary tool. Whenever you see some findings on your pelvic X-ray, you need to go for the next step. So whenever there is diastasis in the anterior pelvis, you need to send these patients for a CT scan for further characterization of these fractures. And then if there is any birami fractures, if there is any break on one side of the ring, there is high possibility of breakage on the other side of the ring. So whenever you see these findings, you can pick those injuries. So there is no specific, as like AP view will be adequate. So AP view will be adequate. So once you diagnose it, inlet, outlet, there are like different, if there is consideration of or any suspicion of acetabular fracture, even though it's not part of our today's topic, it's better to do oblique views, 45-degree oblique views. They are called Judate views. So AP, inlet, outlet, and Judate views are the standard for pelvic fractures, but AP should be done first. We should look for any fracture, dislocations, and symphysial disruption there, and then further ask for these pelvic images. Okay, so next question.
Are there conditions you do angiography for venous bleeders?
So usually venous bleeders, they tend to stop with our routine pelvic containment. So usually, you don't reach up to the level where you need angiography if the bleeder is from venous, it's with venous bleeder. So usually to stop, it will contain itself, and the patient will start to respond for your treatment. But arterial bleeders, they tend to continuously bleeds, so that like the patient, even though you contain the pelvis, you manage it with fluids and lead products, so the patient still happens to be unstable. It's better to do angio, and then in angio, usually you pick arterial bleeders. So third question is?
Do we send patients for X-ray after applying pelvic binder?
Patients for X-ray, yeah. So if you think the patient is has, like we already discussed, some signs of possible pelvic fracture. So if during palpation, that I didn't mention before, so during palpation, if you find, especially in lean patients, if you find significant anterior gap when you try to palpate the symphysis area, if there is significant gap, it's better to close the patient, if the ring with pelvic sheathing prior. But usually, most trauma patients, we will do our ATLAs, primary and secondary survey, and we will send this patient for adjunct investigations like pelvic X-ray. So once you find that there is significant gap, you can apply. But if you clinically suspect there is significant diastasis, you can also apply closer, because like you shouldn't wait until the patient bleed, because you are going to send the patient to X-ray and then wait them to come back in the leg. So you should make the patient stable before sending these patients to radiology. In most Western or like other setups, they have every setup is at the door of the emergency, so they have they can do everything there. So, but our X-ray departments are a little bit far from X-ray, and it will take a little bit. So if you suspect that there is significant diastasis anteriorly by clinically evaluating the patient, you can apply and close the ring and send for X-ray. The only problem will be when you take X-ray, the pelvic ring is already closed, so you might not be able to pick these injuries. That's why we already discussed indirect signs of unstable pelvis. So you should look for those injuries, and then if you find those, send the patient for further pelvic X-ray imaging and CT scan. Okay, so the third question, you have all mentioned resource, at least our major subsection. So most of them, yes. In tertiary hospitals, we have external fixators, at least to put in on iliac crest. The suprastabular pins, we need to have a fluoroscope, but the least we can do is having a pelvic binder and pelvic sheet application. But in most setups, we have, in most tertiary setups, we have external fixator, at least. So you can apply external fixator and then send them to, that's why we, at the start of our session, we listed out some indications to transfer these patients to a trauma center or a better setup where they can get a better treatment. Okay, so how the fifth question, right? How the availability of multidisciplinary trauma surgeons in our country? It's a little bit difficult. So still, there are like we have some mentioned trauma centers in our country, especially only in Addis. We don't have any trauma centers outside of Addis. But still there, the multidisciplinary team is lacking. So we don't have, at the trauma bay, we don't have all the listed physicians. We only have emergency and critical care residents or seniors or emergency nurses, but we may not find, usually there is no like complete team, like all the neurosurgeon, orthopedic trauma surgeon, anesthesiologists at the scene, at the front of trauma center. But I think currently maybe we are on the way. I think we are on the way of having this kind of systems. So 6.
What should we do?
What should we do if patient is catheterized? There is nothing you can do. What can you do? Like you can't remove, but like if there is any suspicion of urethral injury, it's better to have a urologic consult. So the problem is catheterizing these patients for suspected urethral injury. Most patients might have incomplete injuries, urethral injuries. So whenever you try to catheterize these patients, you might complete the urethral injury. So complete injuries, I think, is challenging for, or you are making it difficult for urologists to repair these injuries. So if you see any signs of urethral injury, don't try to put transurethral catheter. So if it's already been catheterized, there is nothing you can do. It's better to have a urologic consult if there is high riding process or if there is any bleeding inside in the urine bag. So after that, they have to deal with it. So the seventh. What is the golden time for pelvic fracture in patients with hemodynamic stable patients? So if hemodynamically stable patients, so golden time, it's better to do it early. So like it's called early appropriate care. So if you could be able to manage the patient, it's better to stabilize the patient because the patient will be free of pain, and then the patient could be able to ambulate. So prolonged hospitalization, prolonged bed rest will result in increased risk of deep venous thrombosis and some lung infections, urinary infections in the lung. So if the patient is stable, it's better to do it the next day. There is no reason to delay these surgeries. So like you should be able to fix these patients and then let them, if it's indicated, ambulate with depending on which side of the pelvis is injured, to touch weight bearing, or you should be at least able. This patient should be able to sit comfortably, turn side to side comfortably. So it's better to do it earlier. So we don't even want these patients to have persistent pain due to delayed fixation. The only problem will be when to fix, definitively fix these patients. So usually you can fix them up to 7 to 10 days once the patient is stable out of inflammatory surge, which is caused by trauma. Usually it will take 3 to 5 days. For pelvic traumas, you can fix it 7 to 10 days. For polytrauma, hemodynamical unstable patient, after you manage the hemodynamic instability, after the biomechanical markers for inflammation and for poor perfusion has stabilized, like serum lactate, base deficit, mucosal pH have been stabilized, and then markers for also inflammatory markers like interleukin 6 has been normalized. You can manage them earlier, the earliest as possible. Okay, so what is 8? So difference between vertical shear and anterior posterior. So vertical shear is, as I said before, is the mechanism is different. So the common mechanism is fall from a height. So fall from a height and landing on one side of the. So like most part of the energy will be transferred on one extremity, and which transferred into ipsilateral hemipelvis, which tear the whole ligaments anteriorly, posteriorly, and then result in superior displacement. The anterior posterior compression, the failure will start to begin anteriorly. So depending on how severe it is, it starts to progress to posterior and posterior. So usually vertical shear injuries and type 3, that means all the ligaments of the posterior SI joint are gone. They may act as like highly unstable injuries because when you close the anterior ring, they will open up posterior. So they will start to act as similar unstable pelvic injuries. But like vertical shear, at once it will rupture all the ligaments or fracture the bones and will lead to vertical shear of the hemipelvis. Okay, so how do you check unstable pelvis in trauma patients? When you can't really say it's unstable, that's spiral. Check exactly. I don't get the question. How do we check unstable pelvis in trauma patients? And when we do, so these are like on radiologically, I have already mentioned it. There are indirect signs. To repeat them, we start from posterior. If there is any avulsion of L5 transverse process, it might indirectly show there is avulsion from vertical shear or avulsion from the iliolumbar ligaments. The other is avulsion over the lateral part of sacrum. If you see this, even if the pelvis is reduced, you should consider highly unstable pelvic injury. Avulsion over the ischial spine, avulsion over the ischial tuberosity. These are the things that you should consider indirect signs of unstable pelvis. So instability, it doesn't have to be like gross instability, especially in biochemical mechanical means. So if it's anteriorly opens up, that is unstable in rotation. So it's rotating externally. So that is unstable in rotation. So if it has shear upwards, it's unstable vertically. So instability, maybe the patient might have mild instability in the pelvis and then significant and severe instability in the pelvis. So there is another classification, which is tile classification. The A part or A group, they are grouped under A are both vertically and rotationally are stable. And then in B group, they are rotationally unstable. That means there is either external rotation of hemipelvis or both of the pelvises or internal rotation of the pelvis. And then in C group, there is vertical instability. So that's how we define pelvis instability. In bi-rami fractures, whenever there is, we have two ramus fractures. So be it on the right, on the left. So bi means two. So if you have two ramus fractures, it's called the bi-rami. If you have the third one, tri-rami, and then if there are four fractures, it's a quadri-rami fracture. So it's just a number of ramus which are fractured. So what's the ideal time to start? It's better to start immediately. So it's better to start immediately. So for pelvic, spine, hip injuries, whenever you find the patient, you should start these patients on thrombophylaxis because these patients are at high risk of deep venous thrombosis. So for patients who came late after 72 hours, it's indicated to do venous Doppler ultrasound, and because the risk of thrombosis is higher at that time if it's delayed without starting this thrombophylaxis. So it's better to do Doppler for all patients who present with pelvic fracture, spine fracture, hip fracture, which stays more than 72 hours. First, we need to do Doppler ultrasound, rule out DVT. If there is any DVT, we should start them on DVT treatment. If there is no DVT, we should start them on thrombophylaxis. So for all patients, as early as possible, you should put these patients on thrombophylaxis. How can we immobilize patients with internal bleeding and comminuted fracture? I don't get the point. Like, can you further describe how can we immobilize patient with internal bleeding? You mean pelvic bleeder and comminuted fracture? So just I'm not really sure whether I get the question, but like if the patient has internal bleeding from a pelvic fracture and then has a comminuted fracture. So first we need to stabilize the pelvic ring or reduce the opening or reduce the volume of the pelvis with pelvic containment techniques we have already discussed before. And then after that, we will plan for a definitive fracture management, be it with external fixator or combined external fixator with internal fixator or internal fixation. Once the patient is stable, most commonly we use some percutaneous fixations for posterior ring, and we will open and stabilize with internal fixation on anterior ring. But if the patient has significant wound anterior or over the surgical sites, if the patient has significant morbid obesity, and then if there is a difficulty of operating this patient due to persistent hemodynamic instability, we may need to just continue with external fixing. So it doesn't change our management whether the fracture has become comminuted or not. So what difference in the management of patients in percutaneous we say if the patient is in second or third trimester? Yes, this is one thing that we should consider. So for most pelvic patients, along with our routine investigations, we should send for serum HCG, like if it's available, or urine HCG. So we need to specifically in like early first trimester of pregnancy, we need to avoid having CT scan because like CT scan will help us to plan our surgery. So for most, and also describe our fracture patterns. So it's better to like do these tests, and then we need to rely mostly on our radiologic X-ray findings rather than CT scan. So it's a must to send for all female trauma patients under childbearing age for serum or like urology, which is standard, so that you can avoid high rate of radiation. The other thing is in like second or third trimester of pregnancy, you should put these patients on the lateral decubitus position, because supine position is not advised due to compression of major veins in the abdomen with the gravid uterus. So it's better to put them on until they are stable on the lateral position. How long does the fracture take? So basically, in our country, we don't see a problem of delayed or non-union unless there is a comorbidity. So we usually lead the patients, if there is one-sided pelvic injury, we mobilize them with bilateral axillary crunch. They can weight bear on the uninjured pelvic side. If it's bilateral, we need to delay weight bearing. But if it's unilateral on the operated side or on the injured side, it's better to delay weight bearing until 8 to 12 weeks, depending on how fracture pattern, age of the patient, and any comorbidities, like which might delay healing for older patients and patients with diabetes and any smokers and the like. We might even to delay up to 12 weeks, but usually we will allow them to allow them to total weight bearing for 8 to 12 weeks generally. So how ideal is systolic pressure 90 acceptable in regard to considering higher pressure cells? So this is one concept of permissive hypotension. So there are different papers, even if there are emergency physicians in this session, they can help us in recent publications. But permissive hypotension is one way to prevent unclogging of these blood clots. So if you like aggressively resuscitate these patients and then rise the blood pressure, you might lose our clot plex. And then ideally, usually what's said is the first clot is the better clot. So we don't need to like raise the blood pressure significantly. So we need to make the patients in permissive hypotension is one thought. So we don't need to like raise the BP like more than 90. So this is a good question. If there is any emergency physician and then recent publication concerning this, you can also share us. Okay.
Thank you, Dr. Kala, for answering all our questions in a very detailed manner.
Okay.
Okay. Thank you very much, Dr. Maalit. Thank you very much, Dr. Kala, for addressing all of the questions in a patient and comprehensive manner. So we are at the final segment. We're going to be sharing the link to the quiz. Okay. The first question is: a 72-year-old male presents as a level 1 trauma patient after being involved in a head-on motor vehicle collision and is resuscitated with 2 units of blood and platelets per mass transfusion protocol. And radiographs of his chest and cervical spine revealed no abnormalities. Figure A below shows his pelvis radiograph after being placed in an appropriately applied pelvic binder, and he was found to have a positive fast examination and proceeds emergently for an exploratory laparotomy, resulting in a trauma team performing a splenectomy. No other intra-abdominal injuries were found, and while the patient is less unstable over the next 72 hours, he continues to require multiple units of blood with gradually decreasing hemoglobin levels, unresolved hypotension, and persistent tachycardia. Furthermore, his lactate remains greater than 5 millimole per liter, and pH remains near 7.1, and an updated pelvic CT scan showed hemoperitoneum, minimal fluid tracking through the bilateral paracolic gutters, and an enlarging hematoma near the base of the corpus cavernosum on figure B, as you can see. So there is no appreciable fluid extravasation near the splenectomy site. So the question is, which of the following is the most appropriate next step? So the first choice is discontinue pelvic binder for a 24-hour period while continuing blood transfusion. B is perform a CT scan of the entire spine to identify the cause of spinal shock. C is consult interventional radiology for pelvic arterial embolization. D is proceed with single-stage anterior pubic symphysial plating and posterior pelvic fixation. And the last choice is proceed with percutaneous posterior pelvic fixation, only with symphysial plating at a later date.
So this is one example that we already discussed. So this patient, because of positive past, so they took him for bleeder control, which was from the ruptured spleen. So this is how it goes. So like whenever the patient is hemodynamically unstable with this pelvic radiograph, the first thing you should do is do pelvic binder, and then if the past is positive or DPL is positive, the first step should be doing laparotomy and arrest the bleeder. So after they arrested the bleeder, the patient still is in shock and then not responding for their fluid and blood management. So the next step is like these patients can have concomitant abdominal and then pelvic injury. So this is significant pelvic ring injury. So they tried to close the pelvis with the pelvic binder, and also they did arrested intra-abdominal bleeder. So the next will be the patient might have arterial bleeder, which is not controlled with pelvic binder. So the next step, as we have discussed before, angiography should be done so that embolization should be done. So we should be able to consult interventional radiologists for possible arterial embolization. So its answer is C.
Thank you very much. The second question reads, a 37-year-old male is struck by a car while walking at night. He's hemodynamically unstable at initial evaluation in the trauma bay. The advanced trauma life support protocols are started and an initial survey is completed. A chest radiograph and pelvis AP radiograph shown in figure A are obtained. What is the most appropriate next step? The first choice reads, the patient should be taken directly to the OR for percutaneous placement of a pelvic external fixator. B reads dedicated inlet and outlet views of the pelvis to better classify the fracture. C is continued resuscitation and immediate CT of the chest, abdomen, and pelvis. D is emergent trip to interventional radiology for pelvic embolization. And E is immediate application of pelvic binder, continued resuscitation, and reevaluation of hemodynamic status.
Okay, so this is a first timer. Like whenever the patient immediately after trauma, they have presented to you. This is open book injury, significant cell diastasis, as we have discussed before. The pelvis is already open. It is already accommodating huge amount of blood, and then clinically also the patient is unstable hemodynamically. So this is the first thing you should do is apply binder or pelvic sheet. So you should be able to close the ring. So like after the patient has come to you at the emergency, you should be able to apply a pelvic binder or pelvic sheet, and then continue resuscitation and then reevaluate. Most of the steps mentioned are after your initial step of containment, that is pelvic binder or pelvic sheet. If the patient didn't respond, you'll go to the next step. So, but here is like it is asking you the first measure you should take. So it will be immediate application of pelvic binder. So you find the patient is unstable, open book injury, you'll apply pelvic binder, continue resuscitation, reevaluation, and then if the patient responds well, if it's didn't respond, you'll go to further management steps. So the answer will be E, immediate application of pelvic binder, continued resuscitation, and then reevaluation of the patient.
Thank you very much. The third question reads, which of the following descriptions is true regarding APC2 or anteroposterior compression? Pelvic injuries as classified by the Young and Birch. A is pubic symphysis diastasis, intact anterior sacroiliac ligaments, intact sacrotibialis ligament, and intact posterior sacroiliac ligaments. B is pubic symphysis diastasis, torn anterior sacroiliac ligaments, intact sacrotibialis ligaments, and an intact posterior sacroiliac ligament. C reads pubic symphysis diastasis, intact anterior sacroiliac ligament, torn sacrotuberous ligament, and an intact posterior sacroiliac ligament. D is pubic symphysis diastasis with a torn anterior sacroiliac ligament, a torn sacrotuberous ligament, but an intact posterior sacroiliac ligament. The last choice is pubic symphysis diastasis with an intact anterior sacroiliac ligament, a torn sacrotuberous ligament, the torn posterior sacroiliac ligament.
Okay. So here we already discussed Youngberger. So it will show you the severity of the trauma. So injury starts from anterior, which is symphysis pubis. So like whenever like initial trauma, symphysis pubis will open up, but the posterior ring will remain intact. So in the posterior ring, we have two ligaments, the anterior and posterior sacroiliac ligaments. So one is just intact posterior ligaments, the anterior will open up. And then two is if the mechanism of injury is more higher than the previous one, the anterior sacroiliac ligament will start to tear. And then three is almost all the anterior and posterior ligaments will tear. So two means anterior symphyseal diastasis with anterior and posterior on the posterior ring, anterior sacroiliac ligament tear. So that is the second type. So answer will be D, pubic symphysis diastasis. Anteriorly, the symphysis species will open up, and then posteriorly from the two ligaments, the anterior sacroiliac ligament will tear, but the posterior one will stay intact. So that's the answer will be D.
Thank you. The last question is, a 25-year-old male is involved in a motor vehicle accident and sustains the injury seen in the figure below. He is intubated in the field and receives 2 liters of LR and continues to be tachycardic and hypotensive. A massive transfusion protocol is initiated. So which of the following is true regarding the transfusion of packed RBC, platelets, and fresh frozen plasma? So the first choice is packed RBC should be transfused until hemoglobin is greater than 8. The second is packed RBC, platelets, and FFP should be transfused in equal ratios. C is platelets and fresh frozen plasma should be given when INR is greater than 1.4 and the platelet count is less than 100,000. This fresh frozen plasma is not needed unless INR is greater than 1.5. And E is platelets should not be transfused unless platelet count is less than 0.5.
Yeah. So this is already like for trauma, for polytrauma patients, hemodynamically unstable, we should be able to give these patients packed RBC, platelet, and FFP at equal ratios in 1:1:1 ratio. So this is the answer is B. This is already like discussed in our lecture. Okay, thank you.
So thank you very much, Dr. Kaleab. So on behalf of Yetena Weg, everyone that has attended so far, I would like to thank you for the outstanding session on the emergency management of pelvic fractures. The presentation was very practical and highly engaging. Your expertise and the interactive nature of the session, I believe, has truly enriched our learning experience. So I would like to extend our heartfelt gratitude to you, to everyone that has joined us. Thank you.
Okay, thank you very much.